She's here Thursday.
She's here Thursday. I have meetings all afternoon. Is everyone here now?
So
is that on? Okay, so we're really lucky to have Kay come and speak with us today. We show a lot of cases of ventriculomegaly versus hydrocephalus, and there still is a lot of debate about how to label it, how to call it, how to use the different breakdowns for mild, moderate, severe. So thank you for taking this challenge on. It's really very important, I think, for us to be consistent and understand what this does mean for our families. And welcome. All right, so I was given the topic of fetal ventriculomegaly or hydrocephalus. It sort of switched, but I think the thought process is somewhat similar. Obviously, they all come in with big ventricles, and the question is, what's the reason? So sort of the questions I want to sort of go over is what is fetal cerebral ventriculomegaly versus what is fetal hydrocephalus. And I think probably the biggest issue here in fetal medicine is how do you counsel prognosis? That's what every parent wants to know in terms of making their decisions or just planning for postnatal. So to go over a little bit of the embryology in terms of the development of the ventricles, you have obviously the lateral, third, and fourth ventricle. Recognizing the lateral ventricles come from the telencephalon, right there, and then you have the third ventricle that comes from your diencephalon. The cerebral aqueduct is from the mesencephalon, which is the same from where your midbrain comes from, and then your rhombencephalon is your pons, fourth ventricle, cerebellum. So to me, the reason why the ventricles are so important is not so much as their functional issue, but the fact that they give you an inclination of what is going on with brain development, depending on when and where you see the ventriculomegaly, and that it should give you an indication of perhaps what else is wrong with the brain that is originating from the same embryologic structures. So the ventricles are present by 8 weeks gestation, the choroid plexus by 9 to 10 weeks. And so in terms of using the size measurements of the ventricles, between 20 and 40 weeks gestation, the ventricular size does not change that much in the area of the atrium. And this is why we use the 10 millimeter mark that we use. And you're thinking, why would we use the same when between a 20-week and a 40-week where the brain more than quadruples in volume? And it's because the brain itself may be growing in terms of the cerebrum, but the ventricles itself does not change much in size. And so you can see how, depending on how the folding of the telencephalon and diencephalon and mesencephalon is going, then you may have alterations in the shape and morphology of your ventricles, and again, giving you an indication of what else may be going on besides just the ventricles being big. And so to me, when we get these fetal ventriculomegaly consults, what we're looking for is what else can we see. So the definition of ventriculomegaly is defined as 10 millimeters or greater at the area of the ventricular atrium of the lateral ventricle, or the trigon. And so it's right where the occipital and the temporal horn sort of meet, right there. And typically it's measured in the axial plane, which you see right there below. But obviously you can also do it in the coronal planes as long as you're getting that same anatomical point. 10 millimeters is at least 4 standard deviations of the mean, the average around 6.5 millimeters. And again, doesn't change much between 20 and 40 weeks gestation. However, to me, if you have a 18 or a 20-week coming in with a 12 millimeter ventriculomegaly versus a 40-week gestation coming in with 12, it means something different, because despite what the ventricle absolute measurement is, the ratio of brain to ventricle size is actually very different at that 18 weeks versus the 40 weeks. So to me, it's not just looking at the absolute measurement of the atrium, but it's also looking at that ratio between brain and ventricle. In terms of the incidence, it's 1% of all pregnancies, and therefore it's the most common referrals for our fetal medicine program, and I think true for most tertiary programs. I would say probably off the top of my head, at least a third of our fetal neuro consults are for ventriculomegaly. So how different ways to sort of describe the ventriculomegaly or think about it. Obviously, one is by absolute size measurements. In the literature, most studies use 15 millimeters as a cutoff between sort of mild or severe. If you want to try to break it down to mild, moderate categories, then 10 to 12 is considered mild, moderate 13 to 15, and severe is 15 and greater. And the reason for that is just because the incidence of finding other associated findings and outcomes cuts off at 15 millimeters, and this is why they use that as the marker for severe. The other way to think of it is the time progression. Is it just transient? You have mild ventriculomegaly and then it regresses. Is it static, meaning it doesn't change in absolute size measurements? And progressive. I also tend to think of a stuttering type of phenomenon because we see that in our NICU as well, where you'll have an increase in size and then it's there static for a period of time, and then you check it again and there's all of a sudden an increase in that rate of growth. And I think that's probably clinically the harder group to be able to evaluate whether you intervene or not intervene, and also giving prognosis, because obviously when we give them prognosis at the time of the visit, it's based on what we see at that time point. We can't predict if it has a progressive or stuttering point after that visit. Then obviously the prognosis may change if you start going from a mild, moderate category to a severe category. The other way to also describe it is laterality. It may just be one side versus both sides. Both sides may be involved, but it may not be symmetric. It may be asymmetric. And then obviously for prognostic purposes, is it isolated finding versus other findings, whether in the CNS or other congenital findings outside the CNS. And there's actually a recent publication out of Israel where they actually looked at it by millimeter, and you're showing an increased risk for having other associated findings. And for me, again, the issue of the ventricles being slightly higher in size, I'm looking for other CNS findings because then that automatically raises the concerns for neurocognitive or developmental disabilities. So in terms of causes, the ways, and this is, for the genetic counselors, they're used to hearing me break this down for the families. I tell them there's basically 5 different categories I'm looking for when they come in referred for fetal ventriculomegaly and we're getting the fetal MRI. Obviously, it could just be isolated, but that's the rule out. And what we're looking for is any type of cerebral dysgenesis or malformation, again, going back to the point that depending on how the brain folds or doesn't fold well, that can affect the shape and morphology of your ventricles, and thereby making the size measurements criteria that we use no longer valid. It can be because of adjacent brain parenchymal injury with associated volume loss, what we call poor encephaly, giving you an appearance of big ventricles, but it's not because of high pressure, but it's what we call ex-vacuo. You can have a combination of either the brain malformation and brain parenchyma, but if it causes a physical obstruction, whether mass effect or aqueductal stenosis, or an intraventricular process, for example, ventriculitis or IVH, all of these are going to cause a imbalance in the CSF production versus absorption process, and thereby lead to hydrocephalus. So I tend to think of hydrocephalus typically being a secondary process. On occasion, obviously, the diagnosis of exclusion is a primary process where we're looking for physical narrowing of the cerebral aqueduct. So again, hydrocephalus, I hate the phrasing that you hear in the internet, and parents spraying and water on the brain. It's actually water within the brain. So what causes hydrocephalus, as mentioned before, it's about either excess production of CSF or a decreased reabsorption of CSF. In terms of excess production of CSF, we typically think of tumors of the corpus plexus or papillomas. These are relatively very rare and uncommon. We've probably only seen less than a handful of cases in a decade in our NICU. Decreased reabsorption, this is the arachnoid villi are reabsorbing the CSF, and it may be that they are not able to work as efficiently, and typically things that can disrupt that process are inflammatory process like meningitis, ventriculitis, encephalitis, where you have a lot of protein products. Hemorrhages, because the hemosiderin can actually also sort of gunk up your drainage systems. And then there's process that we don't actually have a very clear understanding for, and the word, therefore, hydrocephalus is in the label, such as normal pressure hydrocephalus that are commonly seen in middle-aged adult males, or idiopathic intracranial hypertension, which is more commonly seen in females post-puberty. Or you can have just pure mechanical obstruction. And so again, it could be because of aqueductal stenosis, whether actual physical developmental narrowing of the aqueduct, or because of external mass effect because of posterior fossa processes like arachnoid cysts. It could be physically obstructed by inflammation or blood products. Again, obstructing it typically at these foramens, whether at the foramen Monroe, the aqueduct, or at the foramens at the base of the fourth ventricle. This is sort of the way I tend to think of hydrocephalus. In terms of the differential for fetal hydrocephalus, you can see I made this slide for a talk for hydrocephalus in general. The categories and etiologies are the same. It's just the order that you put them in for the different age groups. In fetal, we're thinking of aqueductal stenosis is probably one of the more common ones, but also CNS malformations, in particular neurotube defects, Dandy-Walker malformations, because you've got posterior fossa structures going on, or variants, which I don't like that term, but it's like a hodgepodge of anything that goes wrong in the posterior fossa and encephalocele. You can have intrauterine hemorrhages, both parenchymal and intraventricular, that we've seen. And again, have that same physical process of the blood physically obstructing the foramens, or actually obstructing the arachnoid villus and the ependymal linings. You can also have it as a complication after any in utero brain infection. And typically, again, when I see ventriculitis on any type of neuroimaging, that the incidence is very high, the risk is much higher than I think with just blood products. And then again, very rarely from fetal brain tumors. So just to remind you of the pathway of how CSF flows, it's actually from within the ventricles, going from the lateral third through the cerebral aqueduct to the fourth, and then at the base of the fourth having the foramen of Magendie and Luschka. And then it gets reabsorbed through the arachnoid villi into the low pressure system of the cerebral venous system. Now, one way to think of hydrocephalus, in large part because of how it may inform you in what type of surgical intervention, is whether it's communicating versus non-communicating. Communicating meaning all four ventricles are enlarged. The CSF can flow through that ventricular system, and therefore then the reason for the inability to remove that spinal fluid may be because you have an overproduction, such as the cord plexus papilloma, an inability to reabsorb it, or actually a blockage at the base of your fourth ventricle, at those three foramens at the base of the fourth. Non-communicating hydrocephalus is when you have an obstruction between any of the ventricles. And again, typically the most common is at the cerebral aqueduct, but you can also see at the foramen Monroe, so like the CF patient that Sarah just saw. If you have a SEGA, which is typically at the caudothalamic groove right at the foramen Monroe, you may have a unilateral ventriculomegaly or due to hydrocephalus. So in terms of predicting outcome, so like most things in neurology, whether it's hydrocephalus, seizures, cerebral palsy, the outcome isn't so much the end outcome or evolution of the neurologic condition, but the actual underlying reason for why you have the neurologic symptom. So again, in most cases of hydrocephalus, I typically think of it as being secondary, and you're trying to rule out all the secondary causes, and those secondary causes are more likely to determine outcome than the hydrocephalus itself, unless it's very severe. When you talk about what those other causes are, it depends on whether the brain malformation or injuries are focal and diffuse. the location, because again, we know different parts of the brain do different things, where's the abnormality or injury, and how significant is it, because then that gives me an idea of severity of the functional loss for that location. The severity of the hydrocephalus, anytime you see ventricles, particularly, I know the grading system of 15 and larger is considered severe, but I don't tend to think of it in terms of clinical functional deficit. And, when you're having ventricles that are 20 or millimeters or greater, I tend to consider those patients are ones who are going to most likely have lifelong residual deficits. And then the fourth category that is particular for hydrocephalus is actually the complications from the management and treatment of hydrocephalus itself. So for, recognizing this is a plumbing issue and we're limited with the mechanics and size of our interventions in terms of what age or size they can be for us to put in shunts, recognizing that these shunts are mechanical devices and they themselves can break down, can get infected or fail. And sometimes, you can see this particularly in some patients who, for whatever, have one revision and failure after another, and can literally have more than half a dozen surgery within the first 3 or 4 years of life. That the underlying reason for the hydrocephalus seems to also cause difficulties with their shunts. In terms of there's a lot of protein and obstruction, that same process can also clog up the physical shunt that we're putting in. And I think this last category is the hardest one to predict because there's no way for us to know from their MRI and their underlying cause which one is the one that's going to have a very complicated treatment course with multiple revisions and shunt failures. And it's each of those episodic events, you see them sort of take a step behind in their visual development or impairment or their cognitive issues. And so it's like, again, how many times can you take a hit to your brain without it leaving some long-lasting sequelae? Again, going back to the size, categorization of ventriculomegaly, the severe being 15 millimeters or greater, your chances of finding other abnormalities, whether in the CNS or outside the CNS, is higher, at least 60%, if not more. Again, depending on the more severe the ventriculomegaly, the more likely you're to see associated findings versus the mild category. And again, between 10 and 12 millimeters, you're more likely to have isolated ventriculomegaly versus the 13 to 15 millimeter category. And as I mentioned, in this recent publication that came out of Israel, they examined 278 ventriculomegaly cases, whether unilateral or bilateral, symmetric or asymmetric. And what they broke it down is by each millimeter from 10 to 15 and then greater than 15. And you can see the solid black area is the major findings, the gray area is minor, and then the white is normal. Minor findings were things like a short corpus callosum but otherwise intact, a Blake's pouch cyst, or a benign arachnoid cyst. Major findings are anything like brain malformations like migrational disorders, myeloceles and other encephaloceles. And you can see the actual trend that by each millimeter you're increasing the risk for both major and minor CNS findings, and this was significant. And that in looking at between symmetric versus asymmetric ventriculomegaly, and so meaning both sides are enlarged, but it's slightly asymmetric, that again, with symmetric ventriculomegaly, you're more likely to have major CNS findings versus asymmetric. And again, within each of the size categories. And actually going back to this previous category, typically, again, you can have ventriculomegaly, particularly the mild, that are more likely to regress or be stabilized. The ones that are 15 millimeters or greater, unlikely for them to have regression. They either stay the same or get worse. I think that's always a question that the parents always ask when they come in for fetal ventriculomegaly. What's the chances that this could go away at a subsequent neuroimage? And I usually base it upon size. And so the more severe ones, and again, the more severe they are, even less likelihood of that getting better than with the mild categories. In terms of sort of the philosophy and how I approach counseling for patients, you know, and we do this both whether in fetal medicine or up in the NICU for acute neurologic issues, and we're trying to predict long-term outcomes. One, I find that most people are visual learners, so I usually draw the brain, write out the medical terms. I try to minimize the medical terms we expose them to, because they don't really need to know all of that. They only need to know the diagnosis and then to spell it out for them, because you'll be surprised how many people can't spell, and then, you know, and then if they're not very good with words later on, they don't know how to communicate any of that to anyone else. Severity. Oftentimes, you know, this is whether it's MRI or even EEG. I often find the reports use, you know, clinical or radiographic grading systems of mild, moderate, severe, which is typically not what parents deem as mild, moderate, severe. And that's because for study and clinical purposes, any level of disability should be not something that you want to, so what we would label moderate or severe for clinical grading systems may not be what a parent grades as moderate or severe. And so instead of using severity, I tend to focus more on ranges, areas of function, and what I expect them to achieve or not achieve in terms of the different modalities, because that's a little bit more concrete and understandable, because you know, we use the word severe and they can still be ambulatory, but perhaps not independently, and most parents would not consider that horrible. So I tend to break it down in terms of basic life functions like breathing, and recognizing it is extremely hard to completely not have respiratory function. You have to have an atrophic brainstem to be able to have that knocked out. Sucking is easier to breathing. But then also looking at vision, and not just in terms of primary visual cortex, but anywhere along the visual pathway. You can have what we call cortical visual impairment. Hearing is, again, a little bit hard to knock out unless you knock out the brain. Motor, both in terms of weaknesses in cerebral palsy, and which side of the body, or arms versus legs. Language, again, recognizing that even the comprehension of language for most parents means that they have language, right? It's not about whether they are fluent in an age-appropriate manner. Behavior, sleep, mood, and other higher executive functions. And again, I try to provide ranges. If I think it's going to be on the normal to mild range, then I tell them that, because it's so reassuring for them to understand that when we're talking about disabilities, that we're not talking about profound or severe mental retardation, versus the other way. If you expect them to have severe or profound, to tell them that normal mild is unlikely, because again, I think it makes them better informed to make decisions about postnatal care, not just maybe whether they want to continue with the pregnancy. And then just recognizing that, you know, people define good or normal quality of life very, very differently. And so I don't assume what they define as normal or good. I define for them what I define as a good quality of life, and for me, that means any level of engagement. It does not matter whether you can walk independently or at all. It does not matter whether you have the ability to say, you know, full sentences or not. It's more about your level of engagement. Because for most parents, just the act of smiling and making eye contact is considered, maybe considered good, and so that's how low I define good quality of life, having some level of engagement. So therefore, for me, a poor quality of life would be a vegetative or semi-vegetative level of existence, and after that, you let the parents decide what they feel is a good or not good quality of life. In terms of what we're doing, because obviously, you know, having these referrals in the fetal stages is just the beginning for those who continue with the pregnancy, and again, most of them will survive. I have kids who were born with head circumferences of 50, 52 centimeters, and they do survive. Their breathing are intact, and they may suck and swallow enough to live for a few years. And so the question is, what do we do for them afterwards? This is a research by Nikki Andy Scavage in Kathy Libros's lab in the Developing Brain Research Laboratory. I found this really fascinating. I think she submitted for publication, so she's given me permission to present to you guys. They've looked at fetal brain in 168 women of singleton pregnancies, looking at how different regions of the brain, including the ventricles, grow by actually doing 3D reconstructions and volumetric measurements. And so I've only presenting you here the CSF and ventricular volume measurements and the growth between 20 and 40 weeks. In particular, looking at that there is a difference between male and female. I would say with, for our fetal ventriculomegaly consults, we see a lot of mild unilateral ventriculomegaly that are male that come in, and you can actually see that there is a difference in growth between genders. Looking at total amount of CSF volume within the ventricles, that there is a correlation with total brain parenchymal volume. This correlates in terms of the third and fourth with the cerebellar volumes, but with the lateral ventricles, it doesn't actually show a correlation with cerebral volume. So again, to me, this also sort of, I think, helps inform us in the NICU for our preemie hydrocephalus cases, that you can use the absolute size measurements of your lateral ventricles, and what you're looking at is a ratio of brain to ventricle, and that when that is abnormal, then you have to be concerned that there is hydrocephalus. Also looking, we often see one side being more coming in with either unilateral or asymmetric ventriculomegaly in the mild cases. And here again, you can see in the second trimester that the left lateral ventricle is growing a little bit more rapidly than the right, but then by term they become the same. And this is also seen in the growth of the cerebrum. The right cerebrum actually is larger in that same time period that you see the asymmetry in the ventricular size, and again they normalize, or they become the same or similar by 40-week gestation. I found that sort of interesting because, the question is, at what point do you develop, unilaterally in the human brain, right? In the NICU, again, this is something that is becoming of interest across both by neurosurgeons, neonatologists, and neonatal neurologists, like myself, is trying to standardize our practice and approach to ventriculomegaly and hydrocephalus within the NICU. For me, it doesn't really matter whether it's a preemie or a term baby. It's, again, using the ratio of brain to ventricle. And I personally think physical exam findings, by the time you have them, you've already probably caused some brain injury, and that we shouldn't be relying on physical exam findings, especially in the very early preterm or early fetal gestation, because head circumferences only start after like 30, 32 weeks does it actually start to expand in response to ventriculomegaly. And so waiting for splayed sutures or rapidly increasing head circumference, I assume by the time we're seeing that, we're actually already have some brain injury. And for me, it's not about their surgical outcome, but about IQ points that I'm worried about for this condition. The Hydrocephalus Association, which started in San Francisco in the Bay Area, the local chapter here in conjunction with our neurosurgery department, has put on a Hydrocephalus Education Day. This is for parents and patients, and they just recently had their third one. And I found it very interesting because we don't follow hydrocephalus patients into their 30s, 40s, and 50s. And they had patient panels with adults who were describing, problems like they're horrible with maps and directions, which I find actually really fascinating because the occipital horn stretches more with hydrocephalus, and that's and this is why you get a diplegic pattern for your CP in this age group. You get cortical visual impairment because the fiber tracts, again, going around that occipital horns. But it's also the parietal lobes that are involved and why they all seem to have really bad sense of direction. And then new this year is for teenagers. Children and teenagers, they're starting from 10 to 17-year-olds. This was at the a request of a 4-year-old who was part of our epilepsy summer camp and wanted to know why there wasn't one for hydrocephalus. There are at least almost a dozen different summer camps that were started by Sandy Weinstein, who's a social worker and a physical therapist in her previous life, who started the first summer camp, Camp Great Rock, which was for epilepsy, probably 15, 20 years ago. And now they have one for everything: congenital heart disease, hemiplegia, Tourette syndrome. And so this year they're starting for the first time 10 to 17-year-old children and teenagers with hydrocephalus, where they get to learn about their condition, which I think is extremely important because obviously when these kids leave the home, they go away to college. The question is, how do they set up their support system and recognize when their headaches or other symptoms may be related to their shunt rather than common medical conditions. So fetal ventriculomegaly is common. It's the most common referral for fetal neurology. That the atrial diameter lateral ventricle the size measurements is associated with both CNS and non-CNS findings, and that can affect prognosis. That the neurodevelopmental outcome, whether for fetal ventriculomegaly or fetal hydrocephalus, is varied and really depends on the underlying cause, associated findings, and the severity of the ventriculomegaly. And that treatment for fetal hydrocephalus, unfortunately, just like in our NICU with our preemies, is still limited. It's confined to the postnatal period and also is determined by size because of the mechanical issues related with how small we can make shunts. That's it. Any questions?
Thank you.